Over the next 15 to 20 minutes, we will talk about how steroids are played into the management of severe alcohol-associated hepatitis. And the disclosures mentioned here, none of them I can assure relates to the presentation today. So we will go over learning and updating ourselves that corticosteroids is a suboptimal medical treatment, as we all know, and is the only available treatment for this unique syndrome of severe alcohol-associated hepatitis. And recognize that as a basis for that we need personalized treatment to pick up those who are likely to respond to this treatment. I would focus that personalized treatment mainly MELD-based because that is the talk of today for the sake of time, although we know that there are many, many biomarkers, especially from translational research, whether we talk about inflammatory biomarkers or regeneration biomarkers, which help us determine who are likely to respond to corticosteroids. So I'm going to skip those translational research during this presentation. So I think we have all seen this slide that alcohol-associated hepatitis has a very high short-term mortality, and this is at 28 days. You can see almost 25 to 30% in a severe disease. But what I would like to point out here, and we know that even a moderate disease has a risk of mortality of 7 to 10%, and this is a significant mortality, and this is a disease we tend to ignore, or we don't have any treatments as of today because steroids are recommended only for severe disease. So recognizing this, the field has now promoted research and development of drugs even in patients who have moderate disease, because 7 to 10% 1 month mortality for any disease is a pretty high mortality. So another reason I think we need to focus on alcohol-associated hepatitis is shown in this diagram, where on the left you see the risk of development of advanced fibrosis is about 5 to 10% of people who gets the initial pathology with this, which is steatosis, in these patients who are exposed to the risk factor. But on the right-hand side, you see that risk in that subgroup of patients, about 5 to 10% of patients who develop either asymptomatic or symptomatic alcoholic hepatitis, that risk goes to almost 4 to 5-fold. So 20 to 25% of this group progress to cirrhosis. And this is a pretty fast progression. And that's why this disease needs attention. So I'm going to start right away from this, I think the largest randomized controlled trial of over 1,000 patients in severe alcoholic hepatitis, where the outcome was mortality at 28 days. And I think once and for all, this established a marginal benefit of prednisolone versus no prednisolone. But I think more importantly, the alternative drug of pentoxifylline, it established has no role in the management of severe alcoholic hepatitis. And we were fortunate to gather data of 22 studies in a network meta-analysis fashion, including the STOPA study. So this was after the STOPA was released in NAJM. And again, showing that the impact of steroids on 30-day mortality is almost 47% compared to no steroids. But if you look at mortality after 38 days, there is no benefit of steroids. So that is one limitation of this medication. And based on these data, in spite of a limited data for a short-term benefit of 28 days, ACG, as Anoop mentioned, with a group, I was fortunate with this high-impact group of researchers, including Dr. Kamath, Dr. Shah, Dr. Bataler, and we came up with this recommendation that patients with severe alcoholic hepatitis should be treated with corticosteroids, and pentoxifylline has no role in the treatment of this disease. But the second limitation, as we all know, is that about 30 to 40% of these patients in the beginning are contraindicated for the use of steroids, but recognizing that most of these indications are relative contraindications except pancreatitis. So you should not be using corticosteroids in an acute pancreatitis settings, even if the patient is improving. But most of the other indications like infection, diabetes, bleeding, and hepatorenal syndrome, these are relative contraindications, and steroids can be used after adequate treatment of these conditions, as shown in many studies. That's another problem, that the response of steroids is only in about 50 to 60%, or not more than 50% of these patients. And you cannot determine that response prior to starting corticosteroids. You have to give steroids for at least a week before you can establish response to the treatment using the Lille score. Lower the better, so the Lille score with a range of 0 to 1. So below 0.5, I would say are more likely to either partial or a complete responders, but anything above 0.5 is a poor responder. And whether you continue treatment beyond 7 days or not has no benefit on the survival. So clearly, those who don't respond, you should stop treatment at 7 days. And the reason you need to stop at 7 days in spite of no response is shown in this picture, where you see the risk of infections which these patients are already prone to is increased in the exposure of corticosteroids. As we all know that these patients have predisposition to infections. In a quarter of these patients have presentation like Nipun showed earlier, have already infection in these patients. And you have to screen them before exposing them to steroids. If they're not infected, or the infection has been adequately treated, steroids can be used. But in those who don't respond, you have to stop, because you don't want to expose these patients to fungal or bacterial infections unnecessarily. And then this is, I think, an important slide that we all agree that gastroenterologists and hepatologists in severe alcoholic hepatitis, even if eligible patients for corticosteroids, steroids are not universally or homogeneously used. And these are two surveys in the treatment of severe alcoholic hepatitis. And the survey responses were provided by gastroenterologists and hepatologists. And in about 12% response rate in one, a better response rate in the other survey of about quarter of the responders, you could see the use of steroids in eligible patients was only quarter to half of these patients with severe alcoholic hepatitis. So there is a lot of heterogeneity in the use of steroids, not only across providers, but also across centers. Some centers have a policy not to use steroids in this population. So if we put together all those limitations into this one picture, where you can see that if you have 100 patients with severe alcoholic hepatitis who qualify for at least trying corticosteroids, by the time you end up using corticosteroids and response, you're left with about 30 patients. You have to go through whether they are ineligible for corticosteroids, which is about 30% of this population, and then whether they respond to steroids or not, which is another 50%. So you're left with ultimately 30%. Probably goes down that 30% to even lower, because there is heterogeneity on the use of corticosteroids. So when you see these large series, whether retrospective or prospective multi-center trials, you would see that severe alcoholic hepatitis patients, the use of steroids is about 15 to 20% of the whole population. And that, I think, multiple layers of limitations, which reduces that to about 20% of the whole group. So as we all know, there are many studies or several scoring systems which are used to estimate the severity and mortality risk in patients with severe alcoholic hepatitis. You have an ABIC score, Glasgow score, MADRS score, MELD and MELD sodium score. And we had the opportunity to, in a multi-center international group, in a retrospective fashion, showing that MELD is the best predictor of mortality in this population. And I think in this study was about 2,500 patients, 11 countries and 85 centers, showing that MELD is the best scoring system to predict. And I think it was 90-day mortality in this particular study. So the current treatment of alcoholic hepatitis is mostly MELD-based as of today, and the severity is assessed at a MELD of 20 or above. So less than 20 or less than 20, you don't treat. As I said, it is moderate alcoholic hepatitis. Steroids are not recommended in this group, but this is a group with a mortality, should be recognized, and the field is developing drugs even in this group of population. But the talk of today is focused here, where MELD over 20, where, as we saw, steroids are the first option, and responders continue beyond 7 days for another 3 weeks, and non-responders you stop and look for other options of treatment, which could be either enrolling them in clinical trials or liver transplant, or considering goals of care if the patient is in multi-organ failure. So now moving how we can optimize the treatment of even those who qualify for corticosteroids, because the response rate is only 50%. And this was a question I want to openly acknowledge, that the question was raised in one of the ALD SIG meetings, which I was chairing, and when I was the chair in the last 2 years, 2021. And this question came up from one of the fellows, actually, that we know the lowest limit or lower ceiling of MELD score for starting the corticosteroids. Is there an upper ceiling where the corticosteroids can become ineffective? And that was a very, very valid question coming from a fellow. And people who were part of that meeting, including JP, who spoke in this group, opening talk, and actually led this study. And commendable effort from JP to put together all these centers listed over here, and almost 3,380 patients from 53 centers in 17 countries. And then we analyzed that data in a retrospective registry of patients, and the diagnosis of alcoholic hepatitis was made using the NIAAA criteria. As we all know, the 38-day mortality was the primary outcome. Looking at the steroid versus non-steroid treated patients. And the analysis was very unique, statistical analysis using discrete time survival model compared to the usual Kaplan-Meier survival analysis. So here is the baseline characteristics of these patients. As you can see, the steroid compared to the non-steroid group are relatively younger. There were more females. There were more whites. They are a higher disease severity, whether you talk about individual component of MELD or METRI score, or liver enzymes. However, the proportion of patients with cirrhosis, the albumin, and the liver transplant was similar in the two groups. As expected, the organ failures was less common in the steroid group, especially the patients who had severe end-stage renal disease, especially on dialysis. But this patient doesn't respond to steroids, so very little or a very small proportion of this patient was treated with steroids. So this is the overall effect of steroids on mortality. So on 30 days, similar to our meta-analysis, about 41% survival benefit. But if you look at 90 days, there was no benefit. At 6 months, there was no benefit in a regression model where we control for demographics, underlying cirrhosis, dialysis, and the MELD score. The 30-day outcome remained significant, as shown in many other studies. So I think this is the most important slide of this paper, where you can see the discrete survival analysis. And the discrete factor here is the MELD score, where the MELD score was divided. At each MELD score, the survival at 90 days was looked at. And as you can see, the benefit of steroids, where the p-value is less than 0.05, starts at 21, ends at 51. So the window is 21 to 51. So one of the findings we were able to confirm, which is published in other studies, is that the severe alcoholic hepatitis, the benefit starts about 20, which is also given in the guidelines. So that was the finding which was confirmed. The upper ceiling was 51. But if you look at the maximum benefit, where if you look at the 95% confidence interval, if you look at the upper margin of the 95% confidence interval, which is 20 to 30% response or benefit, you could see the window is 25 to 39. So if you want the maximum benefit of steroids, your therapeutic window is between 25 and 39. Those are the patients who have maximum response to corticosteroids. So the key take-home messages from this presentation would be corticosteroids is the only available treatment for severe disease, but is a very, very suboptimal treatment. It's ineligible in 30 to 40%. Response is not more than 50%, and there is a risk of bacterial and fungal infections, and this risk is unpredictable unless you give it for about 4 to 7 days. So clearly we need more treatments, not only for severe disease, but also for a moderate disease, which currently has no treatment options. And finally, the MELD-based personalized treatment can be given to the most likely responders or the best responders to steroids with a MELD score between 25 to 39, but the window is up to 51 where there is some benefit of corticosteroids. So I would stop here. I'm sure I've raised some questions, so we can take that now or at the end, depending on whatever the organizing team has decided. Thank you once again for the opportunity, and I was excited and glad to be present here this morning or this evening, depending on where we are. Thank you.